Hello guys and welcome back to Counter 10. My name is Ani and on today's episode we're going to continue talking about general pharmacology, and our episode today will focus on Intro to Pharmacokinetics. In today's episode I'm going to cover two broad topics, the first one going through the classical absorption, distribution, metabolism and excretion, i.e. the basic way we talk about each drug's pharmacokinetics, and the second topic being a little bit about compartment modeling, and right at the end, a little bit about infusion kinetics. Now, when it comes to pharmacokinetics, you can go as in depth into it as you want or as little as you want. However, there are a few terms as a basic that you need to be able to describe any drug when you're talking about the PK of that drug. Those basic terms involve looking at the bioavailability of a drug, the protein binding of the drug and the volume of distribution, where that drug is metabolized, i.e. is it in the liver or is it extrahepatic, and where is that drug excreted, i.e. is it renal or is it in extrarenal sites like the biliary circulation. Along with that, you need to know the half-life of the drug as well. Those are the key points you need to know about any drug that you're talking about, but on top of that, there is a few more SAQs that are popping up that go into more of the theory about pharmacokinetics, and hopefully we'll touch on that throughout this episode today. These questions really focus in on the minutiae of pharmacokinetics, and over the last few years have involved questions like describe phase 1 and phase 2 reactions in drug metabolism, describe the factors that influence oral bioavailability, define volume of distribution, and look at the factors that influence this and what assumptions are made with these calculations. And what this general trend of questions tells me is that yes, you could probably get away with knowing the bare bones ADME structure for any drug that you're talking about, but if you really want to be confident in your knowledge of pharmacokinetics, you have to know the basic principles really well, and hopefully we'll go through those basic principles in today's episode, and that's my aim for today, that hopefully by the end of the episode you have the basic principles down pat, so that not only do you know how to describe the important terms in the ADME of the PK of each drug, but you know the theory that goes behind it, and you know the knowledge that can help back you up in both an SAQ and in a Viva setting. So with that said, let's dive straight into it.
1, 2, 3, 4.
If you're following me on Mac 95, the learning objectives I'm going to talk about today span across the ADME topic on Mac 95 and the compartment modeling topic on Mac 95. I'm not going to list out what these learning objectives are, but broadly speaking, we're going to cover in sequence looking at absorption, distribution, metabolism, and excretion. Within distribution, we'll talk a little bit about compartment modeling, and then at the end, we'll talk a little bit about infusion kinetics. To start today's episode though, we have to go back to some basic definitions, and these definitions and terms I'll expand a lot more on as we go through with each corresponding section that they relate to. So in saying that, what is pharmacokinetics? In its simplest sense, it is what the body does to a drug. And we look at what the body does to the drug by looking at the structure of absorption, distribution, metabolism, and excretion. In my head, there is 8 to 9 key terms that you need to understand as your building blocks or your fundamentals for your knowledge on PK. These terms involve bioavailability, area under the plasma concentration time curve, extraction ratio, volume of distribution, first order and second order kinetics, half-life, and clearance. Each one of these terms we'll talk about as it fits in to the ADME structure. So let's begin by first looking at absorption. In its simplest sense, absorption is the process by which a drug enters the systemic circulation from the site it's administered. The rate and extent to which absorption occurs is determined by 3 main factors: the route of administration, the local factors at the absorption site, so these refer to the pH, the tissue blood flow, the thickness of the site, and then finally the third factor is the drug factor themselves. Within absorption, the key term to know about is bioavailability, and bioavailability is defined as the fraction of drug that reaches the systemic circulation. If we were to depict this in a graphical form, we could have a graph which shows the area under the curve if the drug is given in its IV form, therefore having 100% bioavailability, and then overlay this graph with a drug given in a different form. So this could be a drug given in its oral form and drawing an area under the curve for this. And by comparing these two area under the curves on a plasma versus time graph, we can then extrapolate what the bioavailability of a drug would be for a given route of administration. So now we can see how different types of routes of administration affect the bioavailability of a drug. Starting off with the oral route of administration of a drug, this has the lowest bioavailability typically. The absorption has to go through the gut mucosa, in which case there's two important aspects to the gut mucosa, which we refer to as first pass metabolism. This is the metabolism of the drug before it reaches the systemic circulation, and it's achieved by both the gut wall mucosa, which has a minor impact, and the liver itself, which has a major impact. Drugs can have varying degrees of oral bioavailability, which relate back to the drug factors themselves. The important factors that can affect a drug's oral bioavailability are the pharmaceutical properties or the preparations of the drugs themselves. So smaller particles or liquid drugs that are orally absorbed are going to be more rapidly absorbed than enteric-coated preparations. The ionization of the drug can also impact bioavailability, where highly ionized drugs will have a low bioavailability. And an example of this is looking at the absorption of the drug in the stomach, which is going to be a more acidic environment. Drugs that are more acidic to begin with and have a pH lower than its pKa, so therefore majority of the drug is in its unionized form, are going to be rapidly absorbed in the stomach, whereas basic drugs are going to be less absorbed in that same environment. When we talk about pKa, we're talking about the pH at which 50% of the drug molecules are unionized. Drugs can either be weak acids or weak bases. What this means is that if a drug is a weak acid, at a pH below its pKa, the example here being aspirin in stomach, which has a pKa of approximately 3, and the pH of the stomach is approximately 1.5 to 2, therefore the pH is lower than the pKa, more of that drug will be in its unionized form. Whereas a weak base drug, where the pH above its pKa will lead to more unionization, and an example here being local anesthetic administration. Bupivacaine has a pKa of 8 or 8.1, and the pH of the body is 7.4. Local anesthetics are weak bases, therefore more of the drug is going to be in its ionized state rather than its unionized state, and only drugs that are in its unionized state can go through the cell membrane and have an effect on the cell itself. This is why you see people, when they're drawing up local anesthetic or lignocaine for an epidural top-up, sometimes inject bicarbonate into that solution to raise the pH of that solution so more of the drug is in its unionized state, therefore can increase the rate of absorption or the rate of effect of that drug. So this is an important factor, being ionization of a drug, which affects bioavailability. And it doesn't only affect oral bioavailability, but affects bioavailability from all different routes. The other factors that are unique to affecting oral bioavailability will include anything that will alter that passage of that drug through the oral course, through the gut mucosa into the systemic circulation. So this can be gut motility itself, if the patient is vomiting, the effect of digestive enzymes, the interaction of other drugs or food that might also be present in the stomach. And that's why we say some drugs you have on an empty stomach, some drugs you have with food, and if there's any disease of the gastrointestinal tract itself. So this could be as simple as conditions like gastritis, or it could be due to conditions like patients have had surgery where that alimentary tract is not in its normal configuration. The next route of administration we can talk about is the sublingual route. The advantage of this route, which you can either achieve through the nasal or buccal mucosa, is that it has rapid onset and it avoids the portal system. Therefore, it avoids the effect of the first pass metabolism. This is beneficial if you want to give a drug that has a rapid effect and it allows the patient the ability to give the drug themselves, i.e. a GTN spray when someone's having angina. Then the next route we can talk about is rectal route. Again, this will avoid some degree of first pass metabolism. You'll still have the aspect of first metabolism through the gut mucosa itself, but not the first pass metabolism through the liver. Now with this route, there's mixed evidence of whether it's better or has a higher bioavailability than the oral route. However, some drugs can be given through the rectal route if you want to have just a local effect at the rectal site. Then the next route to talk about is the intramuscular route. This route will approach a bioavailability of 1. However, the main factor here that's important to understand is the local blood flow to the muscle itself. If that area is highly vascular, it will achieve a bioavailability of 1 really rapidly and quickly. However, if that muscle group is vessel poor, it will take a long time to reach a bioavailability of 1. The main disadvantage of giving a drug IM is that you can have that unpredictability of when the drug will have its maximum effect. Not all drugs can be given IM. It's painful. It can lead to the risk of local infection or hematoma. But the advantage is that it bypasses the IV route, and in majority of cases, it has a systemic effect pretty quickly. That's why as a backup in most pediatric cases, you have a sucks drawn up with a blue needle to use IM in case you can't get IV access. Another route to talk about which kind of goes hand in hand with IM is the subcutaneous route. This one again has a higher variability than the IM route, and its bioavailability can approach the same as IV, therefore being 100%, but it's really determined on the local blood flow, even more so than the muscle itself. The classic example I always have in my head when I talk about the subcutaneous route is thinking about insulin. When a patient is well, they have normal blood flow to the subcutaneous region, so they can administer themselves insulin and that will bring down their sugars. However, when a patient is really sick and their sugars are going all over the place and you keep giving subcutaneous insulin and you notice that their blood sugars aren't budging at all, it's probably because that subcutaneous tissue is really void of any blood flow. In those patients, you need to use the IV route to give them insulin because the bioavailability through the subcutaneous tissue is so low. Then quickly finishing up with the other 3 routes of administration, being transdermal, where the main rate limiting step is the absorption across the stratum corneum or the epidermis. Inhalation route, which can be used either to have a local effect or a systemic effect, example here being volatile anesthetic versus something like salbutamol where you want a local effect. And then, importantly to anaesthetist, the epidural or the neuraxial route. And here, it's really important to understand the pKa of the drug to understand what the bioavailability of that drug is going to be. Because drugs that we're administering through that neuraxial or epidural route, we're not actually wanting it to go into the systemic circulation. We're doing a targeted administration of the drug in an area where we want the drug to stay rather than reach the systemic circulation. So those are all the major routes of administration and how they can affect the absorption and more so the bioavailability of the drug. So we've touched on routes of administration, and we've touched on some of the local factors that can alter absorption, and we've also mentioned some of the drug factors themselves being ionization and the pharmaceutical preparation of the drug itself. There are a few other drug factors that we should know about that do affect the ability of the drug to pass through a membrane. These factors involve the lipid solubility of the drug. So typically, if you increase the lipid solubility, it has a higher likelihood to pass through a cell membrane. The protein binding of the drug, which we'll talk about in distribution, but to put it simply, only unbound drug can pass in the plasma across the cell membrane. Drugs that are bound to proteins aren't able to pass through a cell membrane. The other important factors are the molecular size of the drug itself, and here we refer to Graham's law, which states that the rate of diffusion is inversely proportional to the square root of molecular size itself. And another factor that goes hand in hand with this, which brings us all the way back to our respiratory episodes where we spoke about Fick's law. And in Fick's law, we said that the rate of transfer of a drug is proportional to the concentration gradient. And here you had the classic equation where on the numerator, you had the variables of the concentration difference, the area of the membrane, and the membrane permeability itself. And on the denominator, you had the thickness of the membrane. So that's a really broad overview of absorption. And when you think about absorption, think about the term bioavailability and the factors that can affect that, route of administration, local factors, and drug factors themselves. Now, let's move on and talk about distribution. Distribution refers to the process by which the drug is distributed into the interstitial and cellular fluid. The factors that can affect distribution are affected by, again, lipid solubility, where more lipid-soluble drugs are distributed more widely, protein binding, where highly protein-bound drugs are unable to cross membranes, ionization, where the pK and the body pH affect the distribution of drugs depending on whether it's unionized, therefore able to cross a membrane, or ionized, where it's unable to cross a membrane, regional blood flow, where vessel-rich groups will get more of that blood, and then redistribution of that drug, which is when the concentration of that drug in the plasma decreases and the drug redistributes from the other areas that it's gone into. You can see when we talk about the factors that affect distribution, it kind of overlaps with the factors that affect absorption as well. So they kind of go hand in hand. Another thing that goes hand in hand with distribution is talking about compartment modeling. Because we're talking about where the drug is distributed throughout the body, we can bring in compartment modeling to help us kind of conceptualize where a drug is going once it reaches the systemic circulation. In the simplest form, we can divide compartment modeling into either a single compartment or a multi-compartment model. In a single compartment, you have a homogeneous compartment where the drug leaves and enters from the same area, i.e., the drug is administered into the single compartment, the drug evenly disperses throughout that compartment, and then the drug is eliminated through this compartment. In a multi-compartment model, we say that the drug can go into different areas of the body, and so putting the body into different compartments. However, the key thing with a multi-compartment model is that the drug can only be eliminated from the central compartment. So the drug is administered into a central compartment and it must leave through the central compartment. In that time where it's in the central compartment, it can go to various other compartments. So you can have a 2-compartment model, a 3-compartment model, a 4-compartment model, and so on. And classically, we talk about the 3-compartment model, where the first compartment is the central compartment, i.e. the plasma compartment. It's not the exact same, but that's what we refer to as. Then we have the second compartment, which is referred to as the rapidly equilibrating compartment, or the vessel-rich groups. These are 2 separate terms, but are sometimes overlapped when we're talking about the 3-compartment model. And then the third compartment is the slowly equilibrating compartment, or the vessel-poor group. Within transfer of the drug from the central compartment to these other compartments and back into the central compartment, we can describe this transfer as a rate constant, which we characterize as the letter K. And this is what we talked about in our episode of TCI modeling and the understanding of the 3-compartment model to help us understand how a TCI program works. That's probably as much as you need to know about with compartment modeling to have a novice level of knowledge. And if I'm being honest, it's not one of my strong suits, so I just try to keep it really simple when it comes to conceptualizing compartment modeling. What you do have to know well is a term known as volume of distribution, and this term helps us to quantify how much of a drug has gone into whatever compartment modeling we're using. What the volume of distribution is that it's an apparent volume into which the drug dispenses. The key term here being it's an apparent value. That means it's not an exact volume, it's an estimated or a theoretical volume. The calculation for volume of distribution is the amount of drug in the body divided by the plasma concentration. This gives us a value of a number to liters per kilo. And what this number can help us do is to then target how much of a drug we need to give, i.e. the loading dose of a drug is equal to the volume of distribution times the desired plasma concentration that you want to achieve. This allows us to give a milligrams or a microgram dose that we need to give or administer of the drug to get to that desired level. Now, in saying that, you can make reference to different types of volumes of distribution. It's not just one fixed number. You can have a volume of distribution that relates to the volume of distribution at steady state of a drug. You can have it relate to the central volume of distribution, which is what we normally talk about when we talk about a volume of distribution. And that's the number that's commonly referred to in textbooks. So when you talk about a volume of distribution, say of propofol, most people will say that the VD of propofol is 4 liters per kilo. The important thing to remember is that the VD can change in respect to what you're talking about. Now, there's two other concepts I want to touch upon with distribution before we move on and talk about metabolism. The first one is protein binding. So typically when you see a drug's PK information laid out, in distribution, you'll have the VD of the drug and you'll have the protein binding of the drug. In terms of protein binding, it's very simple. There are two main proteins a drug can bind to. If a drug is more acidic, it will typically bind to albumin. If a drug is more basic, it will typically bind to alpha-1 glycoprotein. The important thing to note is that if a drug is bound to a protein, that drug is not available to transfer across a cell membrane, therefore it's not available to have an effect, and that drug cannot be broken down. Only drugs that are not bound to protein can then be broken down and metabolized. The other thing with protein binding relating back to volume of distribution is that we classically say that the protein binding is inversely proportional to the volume of distribution. Therefore, if a drug is more heavily protein bound, its volume of distribution is typically lower. The second thing I want to touch on is ion trapping. There's no great place to talk about this, but it's an important concept that you need to understand, and I think it best fits in when we're talking about distribution. What ion trapping is it describes a phenomenon where the difference in the total drug concentration develops on two sides of a membrane, which have a different pH. The classical example is the placenta. If you take a drug like local anesthetic, which are weak bases, in the normal pH of 7.4, their pKa sits around about 7.8 to 8. So typically 40 to 30% of the drug is in its unionized fraction, which means that this is the fraction that can cross a cell membrane. As that drug crosses the placental cell membrane, within the placenta itself, which is now a more acidic environment with the pH closer to 7.2, more of the drug becomes in its ionized state, therefore is unable to cross back across that membrane, therefore trapping itself within the placenta, and that concept is known as ion trapping. That is why you have to be more careful with local anesthetics when you're administering, say, a regional nerve block to a pregnant woman compared to a non-pregnant patient, and is one of the reasons why you reduce your dose of that drug to increase the safety of that drug. Now we can move on and talk about metabolism. Metabolism is the process of chemical alteration of a drug by the body. When you think about metabolism, don't just think it's how a drug gets broken down into its inactive stage. Metabolism can include either decreasing the drug activity, which is yes, the main thing it normally does, or it can increase the drug activity by conversion of a drug from a prodrug into a drug. An example of a prodrug being codeine being broken down into morphine, and paracoxib being broken down into its active drug. The third thing metabolism can also do is that it can have no effect on the drug itself. That means it doesn't either decrease the activity or increase the activity. It just stays the same. When we look at metabolism in the form of making the drug less active, the main aim here is to take a drug in its lipid-soluble form and make it into more water-soluble. Therefore, it can be excreted either through the bile or the kidney. The liver is the main site where metabolism occurs, but there is extrahepatic sites like the pulmonary circulation, like the kidneys, like the gut itself, like circulating plasma and cholinesterases, where metabolism can also occur. And when we talk about making the drug from more lipid soluble to water soluble, we talk about this in two phases. So we normally say there's phase 1 metabolism and phase 2 metabolism. Phase 1 metabolism includes either oxidizing the drug, reducing the drug, or hydrolysis of the drug. Oxidation is the process of losing an electron, and this is typically done by the cytochrome P450 system. The P450 system is in the smooth endoplasmic reticulum, and it's a superfamily of enzymes, and it's called this because it absorbs light at 450 nanometers. When you classically see a P450 system, you classically see some extra letters and numbers attached to it, like a CYP1A1. All those extra letters and numbers are saying is that they're classifying the P450 system into a family, into a subfamily, and into some isoforms. The more important thing to remember is that people generally associate the P450 system with the liver. It is mainly in the liver, but it also has some extrahepatic sites that can be in the gut mucosa, in the lung, and in the kidney. So oxidation is one form of phase 1 reaction. Reduction is the other form, in which you're gaining an electron onto the drug, and then hydrolysis is breaking down a bond. So those are phase 1 reactions, and in phase 1 reactions, what the modifications have usually achieved is that they leave the drug with a reactive end group. And in phase 2 reactions, you get conjugation to produce a more water-soluble product. There's 5 overall phase 2 reactions that can occur, and these are glucuronidation, sulfation, acetylation, methylation, and glycination. Now you don't need to know what each one of these does in detail, more so just the names of these and that these are phase 2 reactions. I do have a bit of an R-rated acronym that helps you remember these reactions, and that's HD orgasm. I didn't patent that. The key thing to note is that with phase 2 reactions, these are typically occurring in the liver themselves. They can sometimes be in other sites like the spleen or the lung, but typically they occur in the liver. So that's a broad overview of metabolism, and before we move on to excretion, we have to look at some of the factors that can affect metabolism. You have genetic polymorphism, so the classic example here being CYP2D6, and how different genetics of this gene can make someone into an ultra-fast user, a slow user, or an intermediate user. You have the effect of age, where certain age groups, particularly the young, might not have a fully developed CYP system yet. You have environmental factors such as dust, smoke, alcohol, and then you have the effects on the enzymes itself that can either lead to induction of the enzymes or inhibition of the enzymes. Examples of these would be induction of the CYP system can occur with certain anti-epileptic drugs, chronic alcohol use, and smoking, while inhibition can also occur with certain drugs, and a well-known example of this would be amiodarone. Now the one last thing to touch on with metabolism, and it kind of segues really nicely into talking about elimination, is this concept of hepatic extraction ratio. Hepatic extraction ratio allows us to then categorize drugs into those that might be limited in their ability to be metabolized due to a decrease in enzymes available or a decrease in blood flow to the liver itself. And how it's defined is that it's the fraction of drug that's irreversibly removed during the first pass through the liver, and this is determined by both the enzyme activity and the percentage of unbound drug passing through the liver. The way you calculate it is by timesing the hepatic blood flow times the percent of unbound drug times the intrinsic clearance of that drug. Now you don't necessarily need to know that equation, but you need to know the important cutoffs. If a drug has a hepatic extraction ratio of greater than 0.7, it's said that it's flow limited. That means there's lots of enzymes available to break down that drug, but there's not enough of that drug coming in the blood flow for that drug to be broken down at a high rate. If the hepatic extraction ratio is less than 0.3, then we say that the drug is capacity limited. This means that there's not enough enzymes to break that drug. So while that drug is being brought to the liver with the hepatic blood flow, There's not enough enzymes there to keep up with the amount of blood flow that's bringing those drugs to the liver itself. Why this is important is that it allows us to then figure out which drugs are being metabolized at extrahepatic sites. So classically we say drugs like propofol and lignocaine are flow limited. They have a really high hepatic extraction ratio. Because their clearance is above what the blood flow to the liver is, we know that they're getting metabolized at extrahepatic sites. In comparison, drugs like phenytoin and diazepam have a really low hepatic extraction ratio, so we know that these drugs are capacity limited. Now that's a trickier concept to understand right at the end of metabolism, but you might or might not hear the word extraction ratio, so hopefully it just helps you to better understand what that term means. Now let's move on and look at elimination, and this is the final of our ADME. Elimination can either be elimination or excretion, and these two words have very different meanings. Elimination is the process of removal of drugs from the plasma. This includes the distribution and metabolism, while excretion is the removal of the drug out of the body. This is primarily done in the urine, but can also be done in the bile, and there's other sites of excretion as well. These involve the lung, and then other weird or wonderful sites like tears and sweat. So let's then focus in on the two main forms of excretion, and this is renal excretion and biliary excretion. In terms of renal excretion, for drugs to be excreted this way, they must have a low molecular weight because they need to be able to pass through the Bowman's capsule. Typically we say that the threshold is less than 30,000 Daltons. The other thing they need to be able to do is be water soluble, and this is where the phase 1 and phase 2 reactions in metabolism really comes in handy. There are three overarching ways a drug can be renally excreted. The first is through filtration at the glomerulus, and for this, we go back to the drug needing to be small, not protein bound, and water soluble. The second way is secretion at the proximal tubule. This is energy dependent process because you're secreting against the concentration gradient, therefore you're requiring active transport. Here, we can use certain drugs in our arsenal to actually stop the secretion of drugs through this mechanism. Drugs like probenecid will stop penicillin from being secreted at the proximal tubule, therefore increasing the concentration within the plasma and the duration of action of that drug. The third method is diffusion of the drug at the distal tubule. Because this is diffusion, this is a passive process down a concentration gradient. So those are the three main mechanisms of renal excretion. Now looking at the second main way drugs are excreted, and this is through biliary excretion. The key here is that typically drugs with a higher molecular weight can be excreted through this pathway. Again, you want the drug to be ideally water soluble, but steroid-based drugs can also be excreted this way, and a classic example of this would be the non-depolarizing muscle blockers. The process of biliary excretion is an active process, therefore it needs active secretion of the drug against the concentration gradient. Certain drugs can be excreted unchanged, while other drugs can also have some conjugation occurring to it. There's really not much else to talk about with biliary excretion. These are really the two main important excretion pathways that you need to know of. Now the final thing to touch on with elimination is a few definitions of some key terms. The first key term is this concept of first order kinetics. When we talk about first order kinetics, we're referring to the rate of elimination of that drug being proportional to the amount of drug in the body. Therefore, it's an exponential decay. In contrast, we have zero order kinetics, where there's a constant elimination of that drug. Therefore, there's a linear graph with zero order kinetics describing its elimination of a certain drug. The other term you have to know is half-life. Half-life is the time taken for the plasma concentration to fall to 50% of its initial value. The equation for half-life is the log integer of 2 divided by k, which is a constant. A common key mishap with the term half-life is that we commonly confuse it with a time constant. A time constant describes the time taken for the plasma concentration to fall to 0 if the original rate of elimination continued. You can see how this might be similar and confusing But the key thing to remember is that when we talk about half-life and not time constant, what we're referring to with half-life is the decrease in the plasma concentration to 50% of its initial value. The last term to know about with elimination, and maybe the most important, is clearance. Clearance is the volume of plasma from which the drug is completely removed per unit time, where the units are mil per minute. For the kidney, you can describe the renal clearance as an equation where the numerator is the urinary concentration of that drug times the urine volume divided by the plasma concentration. Doing this gives you the unit mils per minute, therefore you can describe clearance as a time measure. So this completes the first section of looking at ADME, and now we'll briefly touch on some infusion kinetics. When I talk about infusion kinetics, what I'm focusing on is the intravenous infusion kinetics. And here we have 5 key concepts to go over. The first is the loading and the maintenance dose regime. The loading dose is calculated using the volume of distribution times the desired plasma concentration that you want to achieve. The maintenance dose can be described in 2 different ways. The first is a really simple and archaic way, which is the repeated drug bolus method, where you're repeatedly bolusing the drug to maintain it at a certain dose. So therefore, an equation for this would be the maintenance dose is equal to the dose that you want to keep bolusing times a dose frequency. The other way you can talk about a maintenance dose is by thinking about it as a constant drug infusion, where at its most simplest form, the equation for maintenance dose would be the clearance of that drug from the body times the desired plasma concentration. Now we know through TCR modeling and our understanding of compartment modeling that it's not just as simple as thinking about clearance. We have to consider redistribution of that drug out of the central compartment and then redistribution back into the central compartment. And this again is what we discussed when we talked about the introduction to TCR modeling in our previous episodes. The second main concept I want to touch on with infusion kinetics is this concept of context-sensitive half-time. You might hear this referred quite often when people talk about a propofol infusion, and what it describes is the time for the plasma concentration of that drug to fall by 50% after discontinuing a continuous IV drug infusion. This is not the same as half-life, but it is very similar. The reason it's not same as half-life is that this number changes with how long the infusion has been going on for, while the half-life of the drug is usually a fixed number. And this is why this term is called context-sensitive half-time and not context-sensitive half-life. A good example to remember with this is that a propofol infusion that's been running for 8 hours has an approximate context-sensitive half-time of 40 minutes. The other key thing to note with the context-sensitive half-time is that people usually interpret this number to think about when a patient will wake up after an infusion is ceased. However, this number does not say that after 40 minutes, once an 8-hour propofol infusion has been ceased, the patient will wake up. What it's simply referring to is at the time for that plasma concentration of that drug to fall by 50% after discontinuing that infusion. So if you think about this number as it's the time for the person to wake up, that's the wrong way to think about it. Then the next term to know about is excretion half-life. So in this context, we're talking about the time it takes for 50% of the drug to be excreted out from the body, not just the plasma concentration decreasing by 50%. This terminology too has an equation linked to it, and we can say that it's equal to the log integer of 2 times the volume of distribution divided by the clearance. The tricky thing here, and the tricky thing I find with pharmacokinetics, is that all these terminologies slowly start to blend into one. The fourth concept to know about with infusion kinetics is the concept of effect site equilibrium. We've already again touched on this when we talked about TCR compartment modeling. What this term describes is the delay that you see in clinical practice from injecting the drug to actually seeing the effect of the drug. If a drug has a short effect site equilibrium time, it has a rapid onset of effect. because it's equilibrating within the effect site really quickly. Therefore, it's reaching its peak plasma levels rapidly. If a drug has a long effect site equilibrium time, then it has a slow effect. So these two things, to simply put it, is just the opposite of each other. Now, the last terminology to know of with infusion kinetics is the time to recovery. And this describes what we're actually really interested in. And that is, when you stop a continuous infusion, when do you expect the patient to awaken? Again, this is not the same as context-sensitive half-time, but it's indirectly related to that as well as the excretion half-life of that drug. When we try to display this in a graphical format, what we see is an exponential decay curve of the plasma drug concentration over time. And the plasma concentration at which a patient wakes up would then be equal to the time of recovery. Now, this is not just simply a pharmacokinetic principle, it also encompasses the pharmacodynamics of the patient as well. And while that sounds really simple and logical, when you can start to connect these pharmacokinetic principles to the pharmacodynamic principles, that's when I think you really start to understand the general pharmacology principles really well. So that was a really quick, broad overview of intravenous infusion kinetics. And again, if I'm being honest, this isn't the topic that brings me the most joy to go over, but it's just something that we have to know and know the fundamentals quite well to help us build our knowledge and really have a good grounding for the higher level concepts. With that said, let's look at some of the past SAQs related to the topics that we've covered today. The first SAQ is from the most recent sitting in 2024B, and the question was, define oral bioavailability for 10% of the marks, describe the factors that influence oral bioavailability for 80% of the marks, and then use one example to illustrate the clinical application of oral bioavailability being the last 10%. This had a 43% pass rate, and as of this recording, there is no model answer for this question. The secret that I want to let you guys know is that there's a lot of pharmacokinetic questions on the KickMRex website, and in 2020, a very similar question was asked, which was define bioavailability for 10% of the mark and outline the factors which affect it for 90% of the mark. So my model answer would be very straightforward. For the first part, the definition would be the fraction of drug that reaches the circulation compared with the same dose given intravenously. And here, I wouldn't draw the area under the curve graph because that's just wasting too much time. Then I would go into describing the factors. The main factors that you can't forget are pharmaceutical preparation, the drug factors themselves, and first pass metabolism. If you want to categorize these, and I think KickMRex does a really good job of categorizing this, you can categorize this into pharmaceutical factors, pharmacological factors, and other factors. Within pharmaceuticals, we've already talked about preparation, so we would say in decreasing order, these lead to decreasing bioavailability. So this would be at the top of the list, solutions, followed by suspensions, then capsules, then tablets, and then coated tablets. Then the other factors would be the particle size, if it's a crystal form, which has better bioavailability compared to an amorphous form, and the degree of ionization of the drug. So you can put this into the pharmacological factors or the pharmaceutical factors. With the degree of ionization, you would say that unionized drugs can transfer across a membrane while ionized drugs cannot. Therefore, we would want to know the pKa of the drug and where the drug is being absorbed. Following on from this, you could also say that lipid-soluble drugs would have a higher bioavailability. And the reason is because they can transfer across that cell membrane quicker. Within pharmacological factors, the most important is first pass metabolism, and this is the degree of metabolic breakdown of an orally administered drug as it passes through the intestine and the liver before it reaches the systemic circulation. And because this question says describe, if you can then say that if a drug has lower first pass metabolism, this enables more of the drug to reach a systemic circulation. Other pharmacological factors would be the degree of gastric emptying and GI motility. If the patient has a gastrointestinal disease, because this would alter the membrane where the drug is being absorbed. If there's any other drug or food interactions, because then you're competing for the ability to absorb that drug. And again, in the back of my mind, I have thyroxine for this because it needs to be taken on an empty stomach. So therefore it's given typically early in the morning before patients have any other drugs. And then we can move on to the other factors. So this can be the clinical factors that you can put in. So if a person's in a shock state, they might have decrease in their splanchnic blood flow, so they might not be able to absorb drugs from the oral route. If they have any kind of previous surgery that leads to a decrease in absorptive surface, that will also lead to a decrease in bioavailability. So those are your kind of broad overall points that you want to hit. And with describe, you just want to put a little note next to each one of these. You don't need to put a lot of the note, but you can't just leave it as a dot point because the question is not asking you to list, which was one of the feedback points within the examiner report. Then for the last 10% of the question, it's asking you to give a clinical example of a drug. And in my head, I just choose opioids because they're the ones that we commonly use in both oral forms and IV forms. So you can pick something like morphine, which has 30% bioavailability, or oxycodone, which has 50% bioavailability. So all you need to say is that if I give 10 milligrams of oxycodone IV, this would be equal to 20 milligrams of oxycodone orally. The other caveat that I would put is that because these drugs are being given orally, their onset of effect is slower than the IV form. And with this question only having a 43% pass rate, I would really have it in the back of my head with a high possibility of being repeated again. Now looking at the next question, and we're just going to do this in reverse chronological order. So I'm looking at 2023 second sitting, describe phase 1 and phase 2 reactions in drug metabolism, illustrate your answer using the following examples, morphine, tramadol, and propofol. This again had another poor pass rate, and that's generally the theme with pharmacokinetic questions. The pass rate here was 23%, but the examiner report is really helpful because it essentially answers the first part of this question for you. So in the examiner report, they've said that phase 1 and phase 2 reactions is the active biotransformation of a molecule to increase the water solubility, i.e. the polarity, and thereby increase excretion in either urine or bile. Phase 1 reactions are done by adding or exposing a small polar group, and this increases the polarity slightly and may also provide the attachment point for a phase 2 reaction. Remember the three ways that we can do phase 1 reactions were hydroxylation, oxidation, and reduction. These are commonly catalyzed by the CYP450 system, and they're mainly in the liver but can be in extrahepatic sites. Phase 2 reactions is the joining of the large polar molecule onto the drug, and that is referred to as conjugation. The main phase 2 reaction is typically glucuronidation, and that's the most important to know, and glucuronide is synthesized in the liver from glucose and is joined to drugs usually at a hydroxyl group. Following this, the drug can then be excreted through the kidney, in the urine, or through the biliary system. And in the second part of the question, you have to ask yourself, why have they picked these certain drugs? So why have they picked morphine, why have they picked tramadol, and why have they picked propofol? With morphine, you know that there's going to be an active metabolite. So in phase 1 reaction, you have the process of morphine being converted into normorphine. In phase 2 reactions, you get the production of M3G and M6G. And M6G is a very active metabolite with potent analgesic effects. And the important clinical significance is that if that active metabolite accumulates, say in a patient that has renal failure, then you can have a prolonged duration of action of the drug. And you need to increase the duration interval between readministration of the drugs and be careful if the patient has underlying renal failure. The same thing goes with tramadol. Tramadol gets converted into M1 and M2, and M1 has great opioid receptor affinity. So again, in patients you have to be worried about with renal failure, you can get accumulation of the active metabolite leading to longer duration of action of the drug. The other thing with tramadol is that it can have genetic variation because people can have variations in their CYP2D6P450 system. Some people can be ultra-fast metabolizers, and this leads to a rapid breakdown of the drug, but can also mean a rapid production of that M1 active metabolite. Then with propofol, the important thing here is that none of the metabolites of propofol are active, and majority of propofol bypasses the phase 1 reaction and can go straight to phase 2 reaction and get metabolized and then be excreted out from the urine. So even if you don't know the exact enzymes that are working on morphine, tramadol, and propofol, you should be able to go back to your first principles and say, what is the important thing with this drug? And use that and just lay that out on your answer if you can't remember all the different names of your CYP system and what happens in phase 1 and phase 2. What hopefully the examiners are looking for is broad understanding of these drugs, because once you pass your part 1, you don't remember these reactions, but you know this drug has an active metabolite, this drug does not. This drug I have to increase the duration interval if the patient has acute or chronic renal failure. And those are the things that are important from a safety perspective when administering and prescribing drugs. Then the next question is from 2022 first sitting, which was describe the factors determining transdermal uptake of drugs. Using examples, outline the advantages and disadvantages of transdermal administration of drugs. This question had a 57% pass rate, so a very good pass rate for a pharmacokinetic question, and the examiner report was very straightforward. Firstly, they split it up into 2 domains. The first domain was to discuss a clinically relevant example of a pharmacokinetic principle, being the transdermal uptake, and the second domain was to demonstrate a meaningful advantage and disadvantage. Therefore, not really useful, it's just repeating the question again. What I do think is important from this examiner report is the nugget of using the fixed equation to guide your answer and show your understanding of the transdermal uptake route. I think the best model answer for this question goes back to ketamine nightmares, which starts off with just a basic definition that transdermal route involves the absorption through the skin, and the path of the drug absorption goes through the patch which is put on the patient, the epidermis, the dermis, and then the blood vessels. The drug can be locally acting or it can be given for systemic acting function. Local acting would be typically drugs like EMLA that you're putting on patients before you cannulate them, and systemically acting could be a GTN patch, a fentanyl patch, or a buprenorphine patch. Then if you go into the factors determining the rate of transdermal uptake and use the fixed equation or the fixed law, which states that the rate of uptake is dependent on the diffusion coefficient times the gradient times the surface area divided by the thickness of the barrier. And with this equation, you can literally talk about each one of these factors. So you can increase the gradient by having more concentration of the drug on the patch and having higher blood flow moving that drug away so that concentration gradient remains as high as possible. You can increase the area by increasing the size of your patch that you're putting on the patient. And then you can increase the diffusion coefficient by choosing drugs that naturally have a higher lipid solubility, and that's why you choose fentanyl rather than, say, morphine for a transdermal patch, and by selecting drugs that have a low molecular weight, so have a low size measured in Daltons. And ketamine nightmares has the 500 Dalton rule, so you want drugs less than 500 Dalton in size. In terms of thickness, you can also manipulate that by carefully selecting what side you're putting the patch on. Here you can put some clinically relevant information in. So patients that might be on systemic steroids might have thinner skin, so therefore their dermal thickness might be lower than patients that aren't on systemic steroids. The second part of this question talks about the advantages and disadvantages of this route. And when you talk about advantages, I think you have to mention that this route is convenient, it's painless, and it's non-invasive. The main cons is that it can lead to variability in uptake. The effect of the drug can happen often at varying time intervals. So if you take someone with a buprenorphine transdermal patch, their peak effect is only occurring somewhere between 48 to 72 hours. So this can be a clinically significant safety breach because the patient might not be observed when they're having peak effect of that opioid. The other major drawbacks is that these patches can be inadvertently removed. They can often be hidden and therefore you don't know that they're on patients, so you can have co-administration of other drugs, leading to potential major medical errors. And again, with this second part of the question, you don't necessarily need to have done this question in the past, but as long as you think about it logically, you'll be able to make a really good advantage and disadvantage list for this answer. Then moving on to the last SAQ for today, which was asked in 2021 second sitting, which was define volume of distribution, what factors influence the size of volume of distribution, and the second component of this question being, how may it be used in the calculation of a loading dose, and what assumptions are made in this calculation. This had a 60% pass rate and has been asked 3 times now in the past, and again, if you refer yourself back to the Kick'emRex website, this question has been asked multiple times in the ICU exam. The key things here with the examiner report was to have a correct definition of volume of distribution, discussion on the drug, patient, and pathological factors which influence the size of the volume of distribution, and in the second part of the question, you were asked to explain your equation for loading dose, which incorporated correctly volume of distribution, and outline the assumptions made with the above calculations based on some pharmacokinetic principles. So with this model answer, I think the most important thing to remember with the definition is that it's an apparent volume of distribution into which the drug disperses in order to produce the observed plasma concentration. And because it's the observed plasma concentration, the volume of distribution can change depending on when you're observing the plasma concentration. You can have an initial volume of distribution, a steady state volume of distribution like we've discussed, or what we commonly refer to as the central compartment volume of distribution. So the key thing again to reiterate is that it's not a physical volume, because the volume you can get can be potentially larger than the total body volume. And if you really have time with this question and you think you can absolutely smash it, you can put those different types of volume of distribution in there as an example. If it was me answering, I would just move on and talk about the determinants, and I would classify the determinants as per the examiner report. So drug properties that can affect it, patient factors, and then pathological factors. In terms of drug properties, you're trying to think of what are the drug properties that make the drug stay in the plasma, in which case your denominator will be high and your volume of distribution will be low, or what are the properties that make the drug disperse out of the plasma into its effect site, in which case your denominator will be low and your volume of distribution will be high. And the way I think about this is again go back to the drug propofol. Propofol we know so well, it will distribute really rapidly and it works on its effect site really quickly. Therefore, it must have properties that enable it to have a large volume of distribution. The properties is that it's a small drug. It exists mainly in its unionized form. It is highly lipid soluble. It has low plasma protein binding, and it has high permeability to body membranes. In contrast, if you take a drug which is large, which is polar and hydrophilic, and has high plasma protein binding, it's going to have a small volume of distribution. And that's the way I remember it. If I just think of propofol and the properties it has, and if I reverse it, I can now describe drugs that'll have a high volume of distribution and drugs that have a low volume of distribution. In terms of patient factors, the easiest one to think about is anything that will change the total body water composition of a patient. So total body water will be increased in neonates, will be increased in the pregnant population, and will be lower in the elderly population. If you increase your body water composition, you're essentially decreasing the plasma concentration of the drug when you measure it. That means that you're increasing the volume of distribution. On the flip side, if you have a patient, and this goes into the pathological factors, that's dehydrated or shocked, they're having a reduced intravascular space. This means that the volume of distribution is going to be lower in these patients. When we get into the second part of the question about loading dose, this means that you need to decrease your loading dose for this patient. The other pathological conditions you can put in is anything that will change the composition of how many proteins you have available. Specifically, if you have less plasma protein, say in conditions like liver failure, you're going to increase your volume of distribution. So that's the first part of the question, and when we move on to the second part of the question, we've kind of already touched on the loading dose equation. The loading dose equation is very simple. It's the volume of distribution times the desired concentration of that drug that you're trying to achieve. The main assumption with this equation is that it thinks of the body as a one-compartmental model. It doesn't consider that the drug might be metabolized or excreted prior to blood sampling. It also considers that you have 100% bioavailability of the drug that you're giving, and that equilibration occurs completely in this model. The main issue with using this equation to give a loading dose is that if you simply just use what you think is a volume of distribution for a patient, and you give a drug to achieve a desired plasma concentration, you're going to have very little clinical safeguard in the context of any kind of pathological or patient factors that cause variability in the volume of distribution. And again, this goes back to the critically ill patient that might be shocked that has a low volume of distribution. If you treat them the same way, giving the same amount of drug, you're going to have a very undesired effect with that drug. That brings us to the end of today's episode. It's been a jam-packed episode, and I've still left so many SAQs unreviewed from this section. The SAQs that I haven't touched on, I think, overlap when we talk about intravenous anesthetics, specifically from the last sitting in 2024, second sitting, where the question was asked, these curves show plasma concentrations following the cessation of a 4 mic per mil propofol TCI after 1 hour infusion and a 5 hour infusion. Explain the pharmacokinetics underlying the shape of these curves and discuss the clinical application of these curves. Another question that I haven't touched on is describe the time course between intravenous injection of a general anesthetic agent to loss of consciousness. Explain the delay using pharmacokinetic principles. I think this question in particular already has a really high pass mark and multiple really good model answers for you to review, but I think they kind of overlap with things that we've already touched on in our previous episode, specifically when we looked at TCI modeling. The only other thing that I will say is that if you're trying to fish for potential new questions that might come up, look at the Kick'emRex website. I can't say this enough. Just to give you a list of some of the good questions that have come up on the Kick'em exam that can be easily transferred to our exam. In 2018, they were asked to describe protein binding and its significance. In 2012, they were asked to discuss the pharmacokinetic factors of half-life. In 2009, they were asked to explain zero and first order kinetics and give examples relevant to clinical practice. Going back all the way to 2005, they were asked to define the term context-sensitive half-time and how this differs from elimination half-time. And then going forward now to 2016, they were asked to outline the role of the liver in drug pharmacokinetics. And we've kind of already been asked that when we talked about phase 1 and phase 2 reactions. So my big tip is to look at the Kick'emRex website. Just have a quick read through before you sit the exam so you know what could come up, because these questions typically have a really low pass rate. And I'm going to admit, this isn't one of my strong suit topics. It's really hard to get your head around. There's a lot of concepts that you have to know and a lot of terminology which kind of overlaps. So you need to have a good fundamental knowledge of PK before you go into the exam. So that officially brings us to the end of this episode. In the next episode, which will be the last episode in our general pharmacology series, I'll be covering both variability in drug responses and drug interactions. So until then, good luck with your studying, best of luck to those sitting in the first sitting this year, and I'll catch you next time on Count to 10.